Hello, hello. Thank you so much for joining me for a short overview of Module 7. I want to talk for a few minutes about stakeholder requirements and QI leadership, and just really more of that soft skill side versus such a focus on Lean Six Sigma. Now, the last large chunk of slides, 50 or so slides in this presentation, is not something I'm going to cover in this lecture, but it is a case by case, and it's from the lighter text review of how to use Six Sigma in different case examples. So, for example, there's a case about Bacono Medical Center where it walks through the situation, how they assess the situation and resolved it. There are multiple case examples, and these might be really helpful as you think towards your final project and things that you are interested in writing up and tools that you're interested in using, just seeing, oh, this situation happened, and these are the Lean Six Sigma tools they used in that situation. So I find the case examples incredibly helpful. So I've included them in here, but I do want to say that for many of us, we are working around the clock to learn these tools. We are working and going to school, and it's a lot. And so I don't want you to think that you have to go through all 50 slides. I want you to focus on if there's an example that applies best to you or you find most interesting. All right. All right. So far we've talked quite a bit about measurement, a little bit about analysis, but what are quality measures and how do we use them? So I want to kind of go back to that for a moment. And again, this is from a textbook from Dr. Spath. A quality measure or metric is any type of measurement used to gauge a quantifiable component of performance. Anytime we can collect data, and oftentimes it's quantifiable. Sometimes it's thoughts and feelings and perspectives and complaints, but we can make those into numbers. How many complaints? What kind of complaints? Right? We can describe them. So any type of measurement. Indicators are statistical measures that give you an indication of process or output quality, and quite often these words are used interchangeably: a measure, a metric, an indicator. So keep that in mind. If someone says, what is our indicator? What is our measure? What is our metric? What is the thing that we're using to gauge our performance based off of? And then we hear that term KPI, key performance indicator, quite a bit. Performance management measures are used all the time. And this is just a quick example here. This is average defects per CAT scan, which is so funny. I had a CAT scan. I've been getting ready to go through chemo next week, and I'm going through treatment for a while, and I had surgery and different things. And I had a CT angiogram, and there was an error. And it makes me laugh because it's the average defects per CAT scan. But when they're saying defects, they're referring to, right, the imaging. There can be issues with the imaging. And so if you think, oh my goodness, there's 2 per a CT as our benchmark, it is not as severe as it sounds. Percentage of C-sections, right, is something hospitals often seek to keep down. So those are measures. Now, quite often we are in some sort of performance management cycle. Different organizations use different verbiage to describe this, but quite often we are starting out by setting standards in that top corner. What are we measuring? How are we defining them? We measure them, we implement some sort of improvement, and we report. Feels a lot like plan, do, check, act, plan, do, study, act, the Shewhart cycle, and a lot like define, measure, analyze, improve, control, a lot like DMAID. When we select performance measures, we want to select ones that are actually linked to our goals, our strategy, or hopefully or what the customers and the stakeholder care about, or what's impacting their lives. Just because, your organization's goal is to, make a lot of cheddar, right? They say they want to have, a lot of revenue this year. We want to maximize encounters and revenue. That's great. That's a goal for a lot of health systems. But how about the things that keep patients satisfied and healthy and keep them coming back so that we can have that revenue? Customer and stakeholder requirements. So there are 2 broad types of measurements that we use. We've got internal and we've got external. Internal are things that you use all the time internally, and they're specific to your organization. It's things you care about. External are things that the Joint Commission, the State Department of Health, right? The Centers for Medicare and Medicaid Services make you track. Now, this slide here is a piece of advice. To be efficient, it makes sense that you align your goals as an organization and your measurements that you're tracking all the time with those that the government wants to see. so that you're not tracking a whole set of measurements over here because the CEO is going to review it and a whole set for external stakeholders. There should be a lot of overlap because what the federal government needs to see, and let's say you're running a health plan, what NCQA needs to see for your accreditation is probably very similar to what it means to provide good health plan services because that's what they do. So there should be a lot of overlap, and the things that you're reviewing internally with your team and tracking and kind of institutionalizing your definition of success, that probably overlaps a lot with those external measures. Now, quite often we'll put together something called a balanced scorecard. You choose a comprehensive set of measures that look at finance and customer requirements or experience, patient experience. Learning and growth. We hear growth a lot, and sometimes those are financial measures or productivity measures. And then we have business processes. That is the old school from Kaplan and Norton, 2005, the balanced scorecard definition. I remember when this was developed. That is a way of thinking about keeping your organization balanced and focusing on all the various things you need to focus on. In the clinical side, we have a version of this. We have several, right? Every organization is slightly different, but we have one version that you see quite a bit, and that's a focus on the cost and the financial measures, clinical results or clinical quality, patient experience, and functional items, operational items. So this is our clinical value compass. Now I'm going to show you a different version again in a minute. Another way to think about it, other than just the 4-tenet balance scorecard, is pillars. A lot of organizations have pillars of excellence. They have strategic values that they align their measurement to. Now, I am very fortunate that I happen to personally know Dr. Quint Studer. I'm very, very proud of that. He works a lot with one of the institutions that I work with. And he's just a fabulous human who has developed a lot of frameworks like AIDIT and others. And so because he's engaged with our faculty, it's wonderful. So he says we should focus on service. Again, that feels like experience, right? Patient experience, quality, people, finance, and growth. Now, people's perception and the service being rendered aren't always the same thing. The best CT and how the patient felt, not the same thing. So you'll see there's a few more categories here. Now, I have some examples that I share that are examples of balanced scorecard. I think I have one in our course that is, an example of one that I made when I used to work as a director of quality in an inpatient rehab environment. There are lots of different ways to support this, but we have to choose our measures and then we have to decide how we're going to use them. So we have to analyze that data in a meaningful way. And so when I say, oh, do you have a data analytics team at your hospital? Does your health department have a data analytics team, or is it mostly just epidemiology? It's the extensive use of data, statistical and quantitative analysis, explanatory and predictive models. So we're explaining what's happening, we're predicting the future, and fact-based management to drive decisions. That is data and analytics. And so sometimes that's descriptive analytics. We're answering questions like what went wrong, what's happening, what can we do about this, things like that. But oftentimes we're doing descriptive statistics. 22% of patients felt this way. Other times we're doing inferential statistics, and we'll say something like women have a statistically significantly higher likelihood of being dissatisfied with their care in our emergency department. Why is that? Probably not the women's fault. Why is that? What conditions do they suffer from that maybe aren't being provided the service that they need? Don't get me started on the amount of research around certain female conditions. I could talk all day about the need to invest in. So depending on the type of analysis you're going to do, you have to collect certain types of data. And so this is very rudimentary. I realize that. I realize you've taken other courses that have talked about data types, but I just want to throw that out there when I talk about things like interval data or categorical data, right? Gender quite often we use a categorical, male, female, other, male, female, trans, right? And then sometimes we're tracking sex at birth, we're tracking gender identity, right? That's different. Ordinal data, patient satisfaction, 1, 2, 3, 4, 5. On a scale of 1 to 5 stars, what would you give me, right? Continuous data is something like age. If I ask for your date of birth, I could track it very specifically, right? Discrete data is things like a number of early prescription refills. There's not 4.5, there's 4 or 5, right? So we track all sorts of data. And then because of that, we can apply different techniques. Now, I do teach a research methods course where I have a bunch of research method lectures where I walk through what is the right type of stat to use based on the data you collected, and how do you choose to collect the right data based on the statistics you want to do. But for today, I want you to really focus on the idea that we're trying to drive decision making. And so sometimes just descriptive stats, just knowing how many patients you had on a certain day, how many waited too long, that's enough to know we've got to implement a change. Now, we've talked a little bit about analysis already and statistical process control, but here is a great example. This is a run chart, also referred to as a line graph, of a really basic, straightforward overview that allows you to see if we may have some issues. This is the volume of breast imaging services, diagnostic and screening visits. Now, data needs context. So when I look at this and I say, okay, what happened in January? Why did we do fewer visits? Is that the holidays? Was it a snowstorm? Right? What's going on? So that is a great tool. Another simple tool is a bar graph, right? If we're looking at a comparison across regions, we could get really sophisticated and turn this into a Pareto chart if we sort high to low and we're looking for root causes. We talked about the Pareto chart already. We've got a histogram. Now, histograms are uniquely different. That's why I'm revisiting these basic data tools, is I want to make sure we're thinking about measures we can collect and quick ways we can share them with leadership. So histograms aren't bar charts. They're not what was the response time in seconds at wellness clinic? No, histograms are creating a distribution. How many people waited between 10 to 20 minutes? That's that tiny slice. That's a stack of people. It's a distribution. How many people waited between 50 and 60 minutes, right? That's what those are. Those are a pile of encounters up to the ceiling, right? If we just stacked everything up, that's what a histogram represents. It's a graphical representation of continuous data. Now, we are putting that continuous data into buckets between 40 to 50, between 50 to 60. Scatter plots, scatter diagrams are wonderful. They help us, and we can look at large amounts of data across two variables. Or like this one here, it's just looking at averages, so not a lot of extra dots. We've got the average star rating, so how high we rate the health plan or the hospital, and the average wait time. So the longer you wait, the lower your rating is by patients. Imagine that. So another thing that we may want to consider is, do we take our measures and our data we're collecting and put them into numerical summary measures? Do we graph them in a histogram and look at things like median, mode, right? Mean, average. Do we look at measures of variability? Someone may have the best average wait time. Sorry, lower wait time is good. But their spread is huge. They have some people that wait forever. Well, that's not great. Their standard deviation is not good. So we look at those things, and we also look at measures of relationships between variables. So we may look, going back to that scatter plot, it is very easy. It's one of my favorite things to do in Excel, to open Excel, choose from recommended charts, make a scatter plot of two pieces of data, looks just like this, and then go in and go add a chart element, add a line of best fit, and add the equation. And within 15 seconds, you know the equation for the relationship between those two variables. Very quick and easy. And you can literally Google, simple linear regression, Excel, and see that very quickly too. I've got a couple videos when I teach finance that I use this for that. You don't necessarily have to do that here. I'm sorry for the extra bonus there. Okay. Predictive analytics. It's one thing to look at what happened, why it happened, problem solve. But what about using data to try to predict next month, to try to predict next year? So this is a branch of analytics primarily interested in future predictions about those KPIs, about the future. So we use graphical and numerical elements to analyze performance, and then we try to say, okay, capacity went up, our utilization went up 14% this month. Could it go up again next month? What are the factors? What are the drivers? We can't just assume we're going to continuously grow at that rate. What caused that growth? And we analyze that. This is an example of a run chart where people, nursing staff, maybe clinical staff, are becoming more and more compliant, still not great, with hand hygiene regulations. And what caused that growth? Well, there was some sort of intervention in May. Things are getting a little bit better, but we have to work on it. Also, people tend to behave a different way when they're being observed. Now, if you'll notice this graph and this slide and the next slide tie together. And I think it's really important if you can have, and you may want to watch this 30-second section 2 or 3 times, if you can have a little bit of a data breakthrough in your mind here, the aha moment, I've had it with this visualization. It has made it so much easier for me to understand data and data organization. So do you understand? Let's start with the fact, and we need to understand that both of these graphs are the same data. They're the same information. We've got one in a histogram. Again, people who are, this is a number of patient requests reported for hospital 1 versus hospital 2. You'll notice they turn them into the bell curves in the second one, but it's the same exact data. Now, if I were to take that data and I were to flip it on its side, it would look like this. Hospital 1, hospital 2. Following me? So the average is 4 minutes. And I do apologize. This is because I said it kind of strange. Response time, not the number of patient requests. So they're plotting the number of patient requests. And then they're saying, how does that impact response time? So we've got some patients waiting 2 minutes, some patients waiting 4 minutes. So it's the number and then how long they waited. They get put in that bucket of wait time. So you can see on this graph very clearly that the patients in, is it hospital 2, are waiting a whole lot longer. It's a looser, wider spread distribution. It's not as tight. And we want, in Lean Six Sigma, we want a tight distribution. We want predictable, positive outcomes, not all over the place outcomes. And so what we're seeing here is hospital 2 needs to speed up. Do you see how we can look at it either way with a Y or an X axis? And do you see how that's what normal distributions are? When I say, okay, we've got a bell curve here, people are like, oh, so I'm like, oh, what are we doing here? It is a stacking of outcomes across categories. Now, theoretically, those categories are interval or continuous data, right? They're a number, but it's, did I wait 2 minutes? Did I wait 2 to 4, 6 to 8? It's a stacking of that timeline. Okay. Why does this matter? Because the tighter, and when I say that, the tighter we can get that curve. If I asked you who's performing better, that tall, narrow bell, the pink one, that is good. They're doing great. They're seeing those patients fast and their average is low and it's predictable. We like that. Okay. So we've got a few more slides here on statistical process control, or control charts in general. And if you remember, we reviewed these pretty distinctly in the lecture on analysis. I talked about the idea of using statistical process control, and I provided you some additional resources in case you wanted to go down that rabbit hole and you're really interested in that advanced statistical analysis. This shows how a control chart can be leveraged very simply. We've got hospital 1 and hospital 2, and instead of stacking the patients, we've got it by day of the week here. Sunday, how long did patients wait in hospital 2? Monday, how long did patients wait in hospital 2? And then we've got hospital 1 above, and you'll notice this data is slightly different. So this helps us look at a factor like day of the week. Control charts help with that. Here's an example, and this looks very similar to some I've created myself and shared in the analysis phase lecture. This is an example of how we interpret control charts. Percentage compliance on some sort of medical record metric trended over time as we're intervening. Now you'll notice this is a lot more sophisticated because they're using a staged model where we've got the lower and upper control limits, 3 standard deviations from the mean for the first year, second year, third year. And some of the examples, again, that I put in our module 4, I believe, my analysis phase lecture, use that same approach where we've staged it. We move those measures of upper and lower control. Here we don't. We've got our mean and our 3 standard deviations above and below with those little dash lines. So these can be fun to use and put together. I will say that I have used some really advanced statistical software, Minitab and JMP and different things to make these, but I still love to just do it in Excel and literally manually put it. I calculate those upper and lower control limits, but then I make them a data element in the chart, right? I just select that data. And it's a lot easier for me and quicker. I can make a chart like this in a couple minutes in Excel. Now, I want to talk our last few slides here before I let you all go and think about some of the remaining slides that have examples. It's the case list of examples of Lean Six Sigma interventions and what tools they chose to use for each. Let's talk about what degree of bundling and unbundling, specific versus broad versus comparisons of data works well. So this is an example of a graph, a very high level graph, and I don't like it. It's too high level for me, of what might be in a board presentation. And they may say our inpatient nurse index is pretty consistent. We rank between the 60th to the 80th percentile. We had one bad month. This is what it looks like. So patients answering questions about their experience with nurses across the full facility. Now, if I go to the next slide, this is a lot better. This is the questions that were asked. Did the nurse treat you with courtesy and respect? Did they listen carefully to you? Did they explain things in a way you could understand? And then the scores that were given. Okay. And this might be something that we shared in an executive level meeting of nurse execs, CNO, meeting with their VPs, looking at the scores across question. Now this starts to get a little bit busy, but I like it even better. This is an individual question, courtesy and respect. So I'd need 3 graphs to cover the data from the last slide. But it's across units. So if I'm the unit manager for Unit 3, Med-Surg, or Unit 4, Telemetry, I know how things went. And I know I'm the one who was really low in month 6. Right? Wonder what happened there, and I can dive into detail. This to me is more helpful than just my data. Unit 4, how did I do? Well, what does this tell me? I want to rebundle. I want to know how Unit 1, 2, 3 did in addition to Unit 4, right? In order to make good decisions. Because Unit 4 is kind of just in the middle almost every month. But I don't know that from just seeing my data. I need that comparison purpose. So as data are aggregated together, sometimes they can lose their context and usefulness. So if we go back to that executive level, one item, this doesn't tell me much of anything. I can't solve it. I can't dig in deeper. I don't know what question was the problem. I don't know what nursing unit needs help. Don't know. Aggregated data can be used in a report card format, but we can't pinpoint what needs to be fixed. So the goal is to get as specific as you can without growing cross-eyed, right? Without being like, oh my gosh, what am I reading? Right? That is our goal quite often, is to get as much information as we can in still a digestible form. Now, so far, and I want to kind of pull us full circle here because we are in week 7 and we're getting ready to finish the course together. So far, we have talked about different models: Six Sigma, Lean, PDCA, also known as the Shewhart cycle. And they all kind of take us to the same place. They just leverage different tools to get us there. Plan, do, check, act, right? And we've spent this whole term discussing define, measure, analyze, improve, control. The idea that we're working through a cycle of making change. And the difference between these two is they were developed by different groups in different countries at different times. But they show us that commonality of the idea that we need to have a plan. We need to collect information. We need to make change. And so Lean, I often partner it with Six Sigma, and I say Lean Six Sigma. Lean is defined as a focused short-term project aimed at improving a particular process. So we follow those steps in the PDCA cycle, but pretty closely. But the idea is the tools, standardizing work, creating a customer-focused user friendliness, and unobstructive throughput. The focus of Lean is efficiency. The focus of Six Sigma is often quality. And efficiency can lead to quality, and quality, if you make efficiency the metric, then quality or performance is efficiency, right? So they're very closely tied together here. Now, when we implement improvements, we have to decide at what level we're going to implement those. Right, and this is where the stakeholder engagement discussion of today comes up. And I know I said I'd let you all go in a minute, but I want to cover just a little bit here. Realizing our process impacts our department, impacts our organization. We have to anticipate unintended consequences. We have to look and see how work that we're doing every day impacts the people around us, impacts patients in ways maybe we didn't anticipate. So, for example, anesthesia, the work that's done in the operating room and the PACU, the post-anesthesia recovery unit, the, the impacts to the patient and family. Who and what affects our process? Those are our stakeholders. Our process, the process given in this example, is a fast track intensive care unit extubation process, meaning we're going to get patients out of the OR, back to the ICU, feeling better, back to a normal nursing unit, extubated, getting the tubes out, and getting them back to their families. This is the goal in a safe and manageable format. And then who's impacted positively? Just about everybody, if we can do that clinical process right. Now, when we talk about implementing improvements, I always focus on small wins. Baby steps is the word we use in public health a lot, baby steps. We begin with the end in mind, where we think about our goal and we progress towards that. We work with conflict and creative tension, and we always have some sort of framework. Lean Six Sigma, DMAIC, the Shewhart cycle. Now, this is something that is so obvious, and yet it's one of my favorite graphics. It speaks to me. Your mission as an organization, if you've taken a strategic thinking class, your mission is who you are, and your vision is who you want to be. So what this graphic is these are steps between who you are and who you want to be. So if you were doing career coaching for someone or meeting with an undergrad student talking about their, first job and what they want to do, it's all about these small steps, staged implementation, small wins to get you to where you want to be. And you notice we've got a platform coming in over those stairs. That's a metaphor for barriers. And you notice underneath we've got performance measurement system. The idea that if I'm measuring it, I can track it. If I can track it, I can change it and I can get to my breakthrough vision. And this is why when we talk about things like public health interventions, like diet and exercise, medication interventions, right? Those are steps to get the patient to where they need to be. When we talk about organizationally, right, measuring things, implementing changes, implementing systems to get us from who we are to who we want to be as an organization. All right. The last slides in here, I encourage you to download the lecture, go over multiple case studies of Lean Six Sigma. So for example, we've got Miami Baptist Hospital who wants to improve their discharge planning process. What did they define? What did they measure? What did they analyze? What did they improve? And then their results. And then we've got Pocono Medical Center. What did they do? So these are each just example cases. So as you're working on your final presentations for your healthcare quality class, sometimes it helps to see, oh, what does a version of that presentation look like? This isn't quite as exhaustive as what I'm asking you to do. I'm asking you to set the stage for me a little bit more, give me some background, and tell me a story in your presentation. But these are 5 slides each. Yours is going to be, a little bit longer. These are 5 slides each of examples. So I think they'd be really helpful to review. All right. All right. Well, thank you so much for taking time to listen and engage. Even though we're remote and asynchronous, I do appreciate you just hearing me out. I encourage you as you go through the program and listen to different lectures. What I like to do sometimes is I will literally, and this helps me focus, I will literally choose a task, dishes, laundry, something I'm doing, and I will listen. And then if I miss something, I'll scroll back again. I'll listen again. I'm an auditory learner. For those of you that are visual learners, right? That's why we have the visual here. But I encourage you, don't be afraid to re-listen to some of this. And don't be afraid when you hear a term you don't understand to reach out to me, reach out to your instructors. But also go in and look. There are so many, now that we live in this age of information between generative AI and what's available on YouTube, go in and look at a few videos on statistical process control. And if you have really specific questions, again, reach out to me, but we can also sign you up for Lean Six Sigma training. We can do a little bit more than what the academic program gives you if that's an interest. Not everyone has the same path, but I don't know what your path is and we don't talk about it. So reach out. All right. All right. Well, thank you so much. Have a great week.